Hi, my name's Kayla Owens, and I'm going to talk about cases 1 and 2 for the case connection assignment this time. So in case 1, we have a newborn girl who was fine at birth, and then 24 hours after birth, she came back into the hospital for lethargy, hypothermia, and apnea. The doctor decided to order a metabolic panel on her to decide between a urea cycle disorder or a beta oxidation disorder. So from what we've learned in this unit already, I feel that a urinary analysis of urinary acids would be the best choice to decide between a urea cycle disorder and a beta oxidation disorder. Let's talk about the urea cycle first. It's used in both the fed and the fasted state. It metabolizes and excretes nitrogen generated by amino acids and protein and other sources containing nitrogen in the body. It takes ammonia and basically it converts it into urea to ultimately be excreted in the kidney downstream. When a disorder of a urea cycle is expected, blood ammonia, citrulline, and arginine levels are checked, as well as urine orotate levels. So now let's compare beta oxidation to the urea cycle. And the beta oxidation is when you break down free fatty acids from the adipose tissue into acetyl-CoA to be utilized for ketogenesis, allosteric activation of pyruvate carboxylase for gluconeogenesis, and as TCA cycle intermediates. So beta oxidation only occurs in the fasted state. When a beta oxidation disorder is suspected, a urinalysis performed to look for the presence of ketone bodies, such as acetoacetate and hydroxybutyrate. If the patient is hypoglycemic and there's no presence of ketones in the urine, the patient is expected to have a beta oxidation disorder. So the best way to distinguish between whether the infant has a urea cycle disorder or a beta oxidation disorder is look at the levels of urinary acids for both ketones and orotic acid in the urine. So there's some other diagnostic tests that could be used to consider for further downstream testing to kind of confirm what the urinary analysis tells us, but they ultimately couldn't be used to singly diagnose one or the other by only using one test. So blood glucose testing could be utilized in the fasted state to confirm a beta oxidation disorder, but could not indicate anything about the urea cycle because it is based off of nitrogen, not glucose metabolism. Also, we could use serum fatty acid levels to help confirm a beta oxidation disorder due to elevation in the bloodstream, but could not indicate anything about the urea cycle because it performs nitrogen metabolism from amino acids. Another thing that could be used is plasma glutamine levels. They could indicate a urea cycle dysfunction. Glutamine is converted to glutamate by glutaminase in the liver normally. If there is low or high levels of circulating glutamine in the bloodstream, when it is brought to the liver to be converted, it's also at higher levels, which would contribute downstream to a decreased or increased amount of ammonia for the urea cycle. Ultimately, a decrease or increase in urea production from plasma glutamine levels contributes to the excretion rate of urea in the kidney. Plasma glutamine would have no effect on beta oxidation really at all because it deals with fatty acids, not amino acids such as glutamine. Okay, going back to the infant's case now, based on the lab results from the infant's blood and urine testing for the metabolic test, she has a urea cycle deficiency. This is due to increased orotic acid levels in her urine, like we already talked about the urea cycle. The elevated urinary orotic acid level indicated urea cycle dysfunction because of beta oxidation, just instead of the beta oxidation dysfunction. The infant had a urinary orotic acid level of 473, and normal is usually 0 to 3, so that is way elevated, as well as blood ammonia levels of 314, and they're normally in the range of 17 to 80, and they were actually rising the whole way to 600 in the infant, so that's really elevated, and a plasma citrulline level that was normal. So something's going on between the enzyme for carbyl phosphate, carbamyl phosphate, and citrulline. So we're going to talk about that next. So I'm going to kind of show you a schematic of like what I just talked about the elevated levels to show you what enzyme is deficient and which ones are working properly. Just give me 1 second. So the enzyme in the urea cycle that is deficient in causing the elevated levels of both ammonia and orotic acid is ornithine carbamyl transferase. Ornithine carbamyl transferase is responsible for converting carbamyl phosphate and L-ornithine to L-citrulline. Citrulline levels are normal, so it indicates that there is an excess of carbamyl phosphate that is being shuttled to the cytosol for pyrimidine synthesis. Carbamyl phosphate is accepted into the pyrimidine synthesis pathway for conversion to orotic acid. That is why there is also an increase in orotic acid production and excretion from the kidney into the urine. So upstream blood ammonia levels are also elevated in conjunction with carbamyl phosphate, indicating that the enzyme carbamyl phosphate synthase 1 is not impaired and working correctly to make carbamyl phosphate downstream. Okay, so that was my explanation for case connection 1. I'm going to do case connection 3 next. So in case 3, we have a 47-year-old male. He presents with severe right toe pain, and he can't put any weight on his right foot, but there's no trauma inflicted on his foot at all. But he's having an increased pain level. So the physician ordered some lab testing, and his physical exam concluded that the 47-year-old man had gout. But we're trying to figure out what the best explanation for his presentation of gout is, because there's a few different scenarios. So before I get into explaining the different ways you could get gout, let's just talk about it in general. So based on the male patient's decreased excretion of uric acid into the urine and increased plasma urate level into the bloodstream, that's his lab test results, I would conclude that the patient has hyperuricemia that ultimately led to his gout and the clinical manifestation of his symptoms. Hyperuricemia is characterized by an elevated uric acid level in the blood. Any urate level over 7 in the blood is considered saturated, and then that's when the symptoms of gout occur due to the precipitation of urate crystals within the joints of a person's body, and it's really common in toes. It presents in other joints, and then it only presents in usually one place at a time. Just a fun fact. There could be several different causes for this, and that's what we're going to get into now. So the first potential cause for an increased uric acid production is deficiency of an enzyme. This is characterized in Lesch-Nyhan syndrome, also known as LNS. This syndrome is most commonly characterized in male infancy and is due to an X-linked inherited HPRT enzyme deficiency that does not allow the purine salvage to occur. So purine recycling doesn't occur during this. When purine recycling does not occur, this causes an increase in uric acid production. So I'm going to show you a schematic of what I've been talking about here. So here's the schematic. It shows us that the HPRT isn't working, so you don't get the downstream GMP and IMP synthesis to go back into purine synthesis. HPRT is blocked, so you have an increase in hypoxanthine and guanine, which contributes to an increase in xanthine, and then ultimately uric acid that goes into the plasma. So you don't just have to have a decreased urine plasma level of uric acid. You can also have a decreased one due to increased renal clearance. So it can really go either way. Infants with LNS can have borderline plasma urate levels because of increased renal clearance, like I said, of uric acids. This means that with LNS, the individual can have an increased uric acid level in their urine and not their plasma, like I said. This is opposite of what plasma and urine acid testing shows with our male 47-year-old patient. I would conclude that LNS is not causing this man's gout due to the fact that he's an older age than the normal onset for LNS, It's usually in infancy because of the genetic cause of the X-linked inheritance pattern. Our male patient also has a high uric acid level in his plasma and lower excretion of uric acid rate from his kidneys. This is not exactly always a cure with LNS and can be the opposite effect, like we had stated before. I would therefore rule out LNS as a cause for this man's gout. Another possible cause of gout is due to an overproduction of purines. In von Gehrig's disease, it's characterized by a deficiency in glucose 6-phosphatase. This means that stored glycogen can never be utilized and therefore is trapped in the hepatocytes. Stored glucose is therefore oxidized through the pentose phosphate pathway to greatly increase the production of the substrate PRPP from ribose 5-phosphate. With an increase in PRPP as a substrate for purine synthesis, there is an increase in purine synthesis and degradation, causing uric acid production downstream. Von Gehrig's disease is usually identified in infancy due to the incidence of hypoglycemia in the fasted state from the inability to mobilize and utilize the stored glycogen for the blood glucose homeostasis. Further fasted blood glucose testing would be needed to rule out Van Gehrig's disease for the specific cause of our male patient's gout. Furthermore, the patient most likely would have been identified in infancy if he had Von Gehrig's disease due to the other metabolic complications that could have arose with the blood sugar and other things as well. I would therefore eliminate Von Gehrig's disease as the cause for our male patient's gout, based on the test results that are provided and the need for additional testing to make a concrete decision. Lastly, the final and most plausible cause for our male patients' gout is due to a decrease in urinary excretion of uric acid from the kidneys. And this is shown in his test results. This is the most likely cause of his gout because like I said, his excretion rate is shown in the test to be 215 milligrams per 24 hours when compared to normal rates of excretion between 335 and 491 milligrams per 24 hours. So now that we know it's because of his decrease in urinary excretion that's causing the buildup in his plasma, let's go ahead and discuss the other information that the patient tells us later after the testing is done. After the doctor ordered all the tests, he talked to the patient more and he further discussed with the patient his diet. And the patient stated that he switched from drinking diet soda to regular soda, and he drinks 4 to 5 liters per day. This change in soda correlates with a higher intake of fructose and high fructose corn syrup that is found in regular soda. This diet modification that the male patient made plays a role in his incidence for the development of gout as well. With increased fructose intake, increased fructose phosphorylation occurs. Increased fructose phosphorylation is carried out by ATP. This leads to subsequent ATP depletion and AMP accumulation. The lack of free phosphate results in the excess can lead to an overproduction of purines and downstream increase in uric acid production, because AMP to IMP that occurs by AMP deaminase, and there's a lack of free phosphate that results in the conversion of AMP to IMP. So now that we know that excessive fructose intake can cause downstream increases in uric acid production, this is what most likely occurred in the patient because it was so drastic. He went from drinking the diet soda to the soda that had a ton of fructose in it, high fructose corn syrup. His body it built up in him, and that's why he got gout. Okay, thank you so much for listening.